Thank you very much for the introduction, and to the organizers for this invitation. I really enjoyed my stay in Israel, and I really hope I will be able to come back to Tuvia, please, next year. You can do something for me, thank you. And it's also a pleasure to see many people who have trained with me at the Toronto General Hospital from congenital heart failure. So it's always a pleasure to open our doors to people who are willing to come to Toronto to get some expertise in different areas. So today what I'm going to talk is a little bit of the management of patients with acute heart failure in the ICU. And I will be a little bit away from the guidelines, and I will give you more our approach to how do we treat these patients. I would like to highlight a few things that was already discussed in the previous lecture, but this is just to the idea of put emphasis on the aspects that we need to consider when we treat patients in the ICU who are admitted with acute heart failure. As you all know, acute heart failure is a rapid onset or worsening of a chronic condition, and you need to implement urgent therapy. And most of these patients, in general, are exacerbation of a chronic process. And as you can see here, there are many reasons that these patients can decompensate. Patients who have chronic process and decompensate and acutely pulmonary edema, hypertension. And then, of course, you have patients who present with acute heart failure due to an acute coronary syndrome. Small proportion of patients present with cardiogenic shock. And then some patients with isolated right heart failure, which are very challenging to treat. And we already hear the large spectrum of patients from asymptomatic to patients with structural heart disease and patients with more advanced heart disease who require a totally different approach, and in some cases the implementation of mechanical assist devices or to put the patients on a heart transplant list. And I added here the INTERMAX classification that we usually use for patients who are being considered for mechanical assist devices. And you will see in the lectures probably this afternoon that we are trying to move away from offering advanced therapies in patients who are on this side of the curve who are crashing, burning, or INTERMAX 1. So if we read from the ADIR registry, these are the type of patients that you are managing patients in the ICU will be facing. It's patients who are elderly, female in general. 50% of these patients have preserved ejection fraction. And then these patients have chronic hypertension, previous MI, 44 and 50% here in Israel of patients with diabetes, patients who present with renal dysfunction or renal failure and atrial fibrillation. So these are the type of patients that you usually see in the ICU with decompensated heart failure. And the problem is that every time these patients get an admission with heart failure, it is known that there is a continuous progression or deterioration of the LV dysfunction, which will lead to increased mortality over time. So in summary, I can say that there are challenges in how to manage patients with acute heart failure. First is the leading reason for hospital admissions in patients above the age of 65. As you see, you can see there are multiple comorbidities associated with these patients. Half of these patients have preserved ejection fraction with the use of some treatments like inotropes, sometimes futile. And then the optimal treatment for these patients is very poorly defined, with not many clinical trials or randomized clinical trials in this area. Now, what have we learned in the management? Well, unfortunately, not much, because the therapy for these patients in the last 20 years is practically unchanged. And as you saw in the previous presentation, based on the surveys, the in-hospital mortality of these patients is between 4 to 7%, 30-day mortality 12%, and the 1-year mortality overall is 28%. So it's still a very difficult population to treat. So I would like to guide this lecture with these three aspects that I think are important to remember when we face patients with acute heart failure in the ICU. The first one is to recognize high-risk patients. And this is sometimes a challenge because patients are not always very well defined. Therefore, the prognosis and the treatment that we start is sometimes very challenging in these patients. The second point is to try to stabilize the patient and to relieve the symptoms. And of course, the third option, and this had to be implemented very fast, is to initiate treatment to improve long-term survival and to prevent rehospitalization. So this is a nice summary to illustrate how do we approach these patients. You are all very familiar with this classification. That sometimes helps, but as I can see you now in one case that I will present, this simplification is not applicable for all our patients. And here you can see that depending on the perfusion and the congestion, you can define the patient, you can have an idea of the prognosis, and that can help you also to define the treatment that you are going to use. Now I would like to share with you a patient, and this is a real patient that it was treated last week. And as I was flying to Israel, I will show you the last slide, which is how do we finish treating these patients. So this is a 54-year-old gentleman with a history of ischemic cardiomyopathy. He has a previous MI at the age of 40, has multiple angioplasties, including an angioplasty to left anterior artery post-MI in his 40s. And he has 2 CABGs. The last one was 2 or 3 years ago. Has severe biventricular dysfunction, and the patient was optimized with medical therapy, and an ICD and CRT device was implanted a year ago. So the patient was very well treated, stable for a while, but progressively in the last 3 to 4 months started developing more symptoms at the point of staying stage D heart failure. In addition to what I told you, this patient has comorbidities. He has diabetes, 20-year diabetes, currently on insulin, has renal dysfunction with an elevated creatinine of 180 to 200 range, has liver congestion and a biopsy showed advanced liver fibrosis, and severe pulmonary hypertension for at least a year based on echocardiograms and right catheterizations. And these are the hemodynamics of the patient. And I will leave you here just to think what are the options, and then we will come back to the case. But the patient was admitted in the CCU last week after being seen in the heart function clinic by my colleague Heather Ross. So the patient was admitted, he was reasonable blood pressure, he was making urine, the creatinine was 180. We put a Swan-Ganz catheter, the CVP was very elevated, it was at 25. The pulmonary pressures, as you can see, were also elevated with a wedge of 28, with a transpulmonary gradient more than 15. His cardiac index, however, was 2.8, and the mixed venous, surprisingly, was 72. So this was the first initial approach, and of course you will say, well, the first thing you would like to do is to start diuresis. And yes, that's where we started. And I will show you the progress of this patient, that it did not do very well just with diuresis. So this is the algorithm of these patients. And as I said, this patient I just presented you was wet, but it was warm, but behaved like a wet and low perfusion patient. So it was very difficult to define this patient with a cardiac index of 1.8. But he was not making urine and the creatinine going up. So that's why I said it's very difficult sometimes to classify those patients in those 4 stages. The treatment of these patients, as you can see here, and this is based on the Canadian guidelines, is to define if the patient has volume, or if the patient has volume and low cardiac output. And in that way, you can define if the patient will require intravenous diuretics, or if the patient will require intravenous diuretic plus vasodilators. And in the case of the patient developing low output syndrome, if the systolic is reasonable, sometimes we start with milrinone. We don't use bolus. We use a dose of 0.275 up to 0.75. And if the patient is low, sometimes we use dobutamine or other pressors if they are needed. Now, in terms of diuresis, as you probably know, these are the mainstay of therapy of heart failure. Most effective therapy to reduce congestion, but there, as you know, there are no large prospective trials in acute heart failure. And the approach of how to treat patients with diuretics is this: furosemide, bumetanide in case of those patients who turn refractory to the use of furosemide. And in more refractory cases, sometimes we use the additional metolazone prior to the LASIX, furosemide, or also we use continuous infusion of IV Lasix. Now, the problem, as you know, diuresis have consequences. These patients have electrolyte disturbances that can predispose to arrhythmias, intravascular depletion, hypotension, renal dysfunction, and activation of the neurohormones and the renin-angiotensin system. So these are the issues of treating aggressively with diuretics. And as you can see from ESCAPE trial, patients who receive more diuretics, there is a nice correlation with higher mortality. So that's why in cases we use vasodilatation, and we know that the addition, in addition to furosemide, is beneficial in these patients, but it's mostly beneficial when you use it within the first 6 hours or 4 hours after admissions in the ICU, and this is based on the ADIR trial. Commonly used are nitroglycerin. We use more nitroprusside, and as you know, based on the ASCENT trial, the role of nesiretide is not that clear in patients with acute heart failure decompensation. And then we go to inotrope therapy, and this is an area that I want to just discuss, mostly intravenous, because there are lectures later today of oral, and I think you will discuss about levosimendan. So inotropes we use basically to alleviate symptoms because they improve the hemodynamics, but as you know, there are serious adverse events. So these are the most common use doses and drugs that we use. As I said previously, milrinone is one of the drugs that we usually use as a first choice in these patients, particularly those patients who had a systolic blood pressure more than 90. We don't use bolus to prevent arrhythmias or hypotension. And this is based on the OPTIMIZE heart failure trial, where basically did not show any improvement in terms of survival versus placebo. And also you can see that here patients who receive milrinone have more incidence of atrial fibrillation and hypotension. Therefore, that's what we use. We don't use bolus on these patients. And then we have other inotropes, and as you can see here, the classic mechanism of the inotropes is to release calcium in the sarcoplasm with interaction between the actin and the myosin. And then you have a good effect of increased contractility, increased heart rate, but of course you have more oxygen consumption, oxygen demand, and arrhythmias. And that's what we have now, new inotropes, which are targeting specific areas in the cell, particularly in the sarcomere, where they interact with the active myosin and without releasing calcium intracellularly. So the advantage of this is that you can have increased contractility without changes in the oxygen consumption parameters. Therefore, there is more efficiency and no increase in oxygen demand. And here you have a list of different inotropes that are currently being used in part of clinical trials. The one I was referring the last slide is the omecamtiv, which is an inotrope that interacts with the crossing of the actin and the myosin, and there are studies showing that improve ejection fraction and stroke index in these patients. The other tool that we have is the use of ultrafiltration in the ICU, and there are some advantages. One of the advantages is that we can adjust the fluid removal volume and rates in these patients. There is a neutral effect in terms of electrolytes, and there is evidence that there is a decrease in the neurohormonal activation by using ultrafiltration. And the first study that was published years ago showed that if you use ultrafiltration versus conventional treatment, these patients have more fluid removal. And then the UNLOAD trial showed that you can also reduce the weight of these patients if you use ultrafiltration versus standard care. And it was borderline significant, but these patients who receive ultrafiltration you can reduce the hospitalizations. And then recently we had the CARES heart failure trial, which sort of changed the way we see ultrafiltration in many centers. So this was a randomized clinical trial using a stepped pharmacological care arm versus ultrafiltrations in patients with acute heart failure decompensation. Patients were assessed at different time points, and the volume status was evaluated. And based on this table, you can see here the patient or the drugs that were adjusted accordingly. So, for example, if a patient has a urinary output of 3 liters, less than 3 liters, the patient went to the next step, so from B to C. And if the patient was taking oral Lasix at less than 80 a day, the initial dose was 40 milligrams, and then bolus, and then continuous IV Lasix. And then the ultrafiltration arm was a rate of 200 cc's an hour. So unfortunately, this trial showed that basically, if you use ultrafiltration, the weight of these patients do not change. It's exactly the same as using conventional therapy. And even worse, this patient has worsening renal dysfunction up to 96 hours. And if you use ultrafiltration, unfortunately, you have more side effects, particularly renal failure, hemorrhage, bleeding, and infections. So the conclusion, and of course, there is no difference in mortality and heart failure hospitalization. So unfortunately, this approach of ultrafiltration in these critical patients showed that the stepped pharmacological therapy was superior to ultrafiltration, at least 96 hours, with a very similar amount of weight loss. So, and unfortunately, ultrafiltration has more side effects. So that's why this therapy is expensive, first of all. Sometimes logistically it's difficult to implement in the ICU setting. It's effective for those patients who are very refractory to the treatment, but unfortunately, based on the evidence we have so far, there is no improvement in survival and little benefit overall. I'm not going to discuss a lot about LVADs and mechanical devices because there is a lecture later today. But this is another option that we have in these patients. We have durable mechanical assist devices like hardware, HeartMate, and then we have the short-term devices. And these are the devices that sometimes we need to consider in patients with acute heart failure. And then we have ECMO, especially for those patients who have problems with oxygenation. We have CentriMag for support with right or left ventricle. And then we have Impella, which I don't think you have here yet. Impella, as you know, you have the 2.5, or what was initially designed for patients going for high-risk angioplasty. We have currently in Ontario the 3.5, and now we have the 5 liters, which is a very, very good pump, temporary, easy to implement, minimal complications. You can keep the patient for a week, 10 days. In Vancouver, there's one of my colleagues that kept a patient on Impella 2.5 for a month. But it's a good temporary device that at least can give you the chance to see if some of the problems the patient is going through can be reverted, and then convert that patient to a long-term device. But of course, again, you had to define what is the ideal patient who will receive an ideal pump, and you had to consider not only cardiovascular issues, such as the presence of shunts, arrhythmias, the presence of or the use of inotropes, valvular disease. Important and very important is the right ventricular function in these patients. And of course, you have the non-cardiovascular considerations, such as the pulmonary function, liver function, renal function, and then other things that will dictate if the patient will be a reasonable candidate. We have different scores when we determine if a patient is a candidate for advanced therapies. These are scores like the Columbia score, the Miller score, and the right ventricular score. But all of these scores were done or defined based on retrospective data, small number of patients, and all these scores were defined based on first generation pumps. So it's very difficult now to use this in the context of the new generation of mechanical assist devices. So this is a very large, important limitations that we have at the time to define what is the best candidate for this type of devices. And I would just like to finish to tell you what happens with my patient. So Thursday last week we have a large discussion about what to do. And we recognized that the patient had multiple comorbidities. It was not a good heart transplant candidate because of the chronic or at least 1 year of pulmonary hypertension, renal dysfunction. He has multiple surgeries. It was definitely a high-risk patient for mechanical assist device. This patient had 2 previous surgeries. The right ventricular was attached to the sternum, and based on the echo and the hemodynamics that I show you, the patient has very poor right ventricular function. But the patient was 54 years old. So after discussions, we decided to optimize the right ventricle. So we implanted an Impella 5 on this patient. And as soon as we put Impella 5, the patient in only 2 hours start making 300, 400 cc's an hour of urine. The creatinine dropped to 170 from 200. And you can see the hemodynamics. These were on Saturday. And you can see the CVP dropped from the 25 to 11. Pulmonary pressures were 42 versus the 68 that it has at the beginning. Reasonable wedge, good numbers with a mixed minus of 72. The patient was still on milrinone and Lasix with a right ventricular stroke index of 10. It was 3 before. So the patient turned only in 24 hours into an ideal candidate. Not ideal, but an intermediate risk for a mechanical assist device. The decision was on Sunday when I was coming here to implant that hardware device through left thoracostomy, and the patient is doing great, extubated, doing very well. But these are the patients that you will be facing, very challenging patients where you need to optimize the patient for the next step, which could be a temporary or a long-term device. So as a summary, I would like to emphasize that definitely the management of acute heart failure has not unchanged in the last years. The core drugs and device therapeutics, except for the Impella that has been used in acute heart failure lately, has been unchanged. And the goals of treatment, as I showed you in the first slides, are to establish the risk of the patient, very challenging many times, trying to stabilize and relieve the symptoms, and to implement as soon as possible treatments that will change the survival of these patients and to prevent rehospitalizations. Thank you for your attention.